Uh, Good afternoon to all. As Senior said, today we are going to learn about communication part 2, that is on communicating bad news and collusion breaking. So we have Miss Manisha with us. Basically, she is a physiotherapist, but she did her master degree in social work. She has 2 years of experience in palliative care. Now she is heading our social engagement department as a session head. Manisha, welcome and over to you.
Thank you, Sister Sheila. So, hi everyone. It's really good to see all of you today, and a very good afternoon to all of you. So, without much delay, I'd like to start with our session. Today, we will be talking about a very delicate topic, that is communicating bad news, and this is something that we, being healthcare professionals and particularly being in palliative care, this is something that we need to be aware of and something that we need to understand in detail. Therefore, I wish that you all have a good time of learning. So moving on to the presentation. Is my screen visible to all of you?
Yes, yes.
Thank you. So today, even though we are speaking mainly about communicating bad news, there are three main topics which I would like to cover. One is communicating the bad news, and the next one would be managing collusion, and the other one would be dealing with emotions. This is mainly dealing with anger and the other emotions that lead to a lot of things in the future. So, communicating bad news. So, what is basically a bad news? When it comes to patient care or palliative care, the bad news is something that the patient or the family does not want to hear from the healthcare system or the healthcare professionals. So, communicating this bad news with the patient or the family is quite a tricky part, where we'll have to listen, we'll have to understand about a lot of aspects and be careful about, because if we don't do it in the right way, it might lead to a very distressed situation. So there are mainly two models in which the bad news is communicated to a patient and the family. The two models are full disclosure model and non-disclosure model. So in this full disclosure model, this is mainly followed in the Western countries. That is, it's in a way where the patient autonomy is given high priority, and when the information is disclosed to the patient directly, and based on the patient's decision, it is decided whether this information has to be shared with the family or not. For example, if I say that a patient who was completely normal 6 months back, after a lot of tests and diagnosis, after a lot of procedures, he or she was diagnosed with cancer, and we need to disclose this news to the patients and family. In the full disclosure model, it will be in a way where the information is shared with the patient directly. And once we tell the patient what the bad news is, this patient decides whether his diagnosis, if it is a cancer, whether this has to be told to the other family members. And the other one is the non-disclosure model. This is a model which is mostly used in countries like India, where the family has a lot of right in the patient's decision making, and patient autonomy is not given so much importance. So in the non-disclosure model, the family is told about the diagnosis or the bad news, and the family decides whether the patient has to be given the information about what the bad news is. So this is, like I mentioned, this is not something that every country, every community practices, but these are two different models which different communities and people from different cultures practice. So another thing that I'd like to talk about is the patient's rights. There are two major things that we have to note when we talk about the patient's right. One is patients have the right to know. That is called patient autonomy, where the patient decides that he wants to know. So in this, when we say that the patient has the right to know, it does not mean that the patient has to know. It means that the patient has the right not to know also. That is, in simple terms, if the patient does not want to know, we do not have to tell the patient. If the patient wants to know, we need to tell the patient about what the diagnosis is or what the bad news is. So this is one question to all of you. Which one do you think is a nice model, a full disclosure model or a non-disclosure model? I'd like you to please unmute your mics and speak up. Please feel free to unmute your mics and speak up.
Full disclosure model.
Okay, thank you so much. So we have a few comments coming in. So everybody says it's the full disclosure model, which seems to be a fair option. So I will talk about it in the next slide. There's another model called individual disclosure model. So this is a model in which so basically in this model, what we focus is that each person is different and each person is unique. And the way each person can accept certain information and process certain information is also different. So based on this, based on the person's individual characteristics or individual decisions, we need to identify whether this patient wants to know or does not want to know. So that is what an individualized disclosure model means. So it says if the person does not want to know, the person should be allowed not to know. And if the person wants to know, so this is one major aspect which has to be given a lot of focus when it comes to individualized disclosure model. That is, if a person does not want to know, it's okay that we don't tell them. But if the person wants to, say it's if the diagnosis of a patient is CA pancreas, and we talk to the patient, and at a certain point, the patient tells us that he or she wants to know about the diagnosis. He does not want to know about the diagnosis. If we try to talk to them have a conversation about this, and they tell us they do not want to have a clear picture of what the diagnosis is, we don't have to tell them. It's as simple as that. But if the person wants to know about the information, we need to assess how much the person wants to know. So in this case, it is very important that the person who is sharing the information has a clear picture of how to deliver the bad news, and they should be having very good skills on how to address this issue. And so there it comes. Who should communicate the bad news? So mostly the bad news that we talk about in palliative care is something beyond our imagination. It's something that is coming into your life, coming into the patient's life, storming into the patient's life all of a sudden, and that is a point where the patient's life is going to completely change. And in these situations, we need to be very careful. We, as in the healthcare team who is managing the condition of the patient, should be very careful, as in how and who should communicate the bad news. So sorry about that. So communicating the bad news, the person who's communicating the bad news has to be a trustable person for the patient. And this person who's communicating the bad news should have enough information about what the medical condition of the patient is, and what the emotional status of the patient and family is too. And with this, it's not easy for communicating a bad news with a family who is almost very eager to know or who does not want to know. Certain people want to know and certain people do not want to know. So it's a very tricky situation. And in these situations, just having the trust of the patient or having enough information about the medical and emotional concerns of the patient is not enough. There should be a skill which has to be developed through practice. So if the skill lacks, then we need to learn how to communicate this bad news with the patient and family. So why do we have to communicate bad news? I'd like to hear. You can put in the chat box as well. Why do we have to communicate bad news? What is the need for that? I hope you got the question. The question is, why do we have to communicate bad news? So we have one comment from Mahima to prepare the patient. Absolutely right. If there's anyone else who would like to comment on it, please do. Okay, I'll move on. So the need of communicating the bad news is okay. We have one more comment to support family members through prayer, which is also in fact a true statement. Support the patient and their family in their decision making for the future. Absolutely true. Thank you for the comment. So the reason why we have to be communicating a bad news is that I mentioned just some of the reasons. One is to finish certain unfinished businesses of life. That is like if there is any financial agreement or any property related issues, or if the bank account passwords have to be shared with the uh, near ones, then all this can be done only if the patient is prepared. Like someone mentioned, only if the patient is prepared for what is coming next. And the next one is planning the treatment, expectation versus reality. So, if a patient does not know about the diagnosis or the prognosis, then what happens is this patient or everybody, nobody wants to be sick. So, everybody will have a thought that if they are sick, they will want to explore new options where they can get medical support. They move from one hospital to the other in search of finding an answer for their illness. So if we have to avoid this, and if the patient and the family has to have a clear idea on planning their treatment, it is very important that the bad news has to reach them. So planning the treatment, the bad news should be communicated. It helps. The bad communication of bad news helps in planning the treatment of the patient. Another one is closure. So every human beings have different emotional attachments to different beings, and they can have very strained relationships with other individuals too. Maybe like if I am considered in a family, and I can have a very bad relationship with my mother, a conflicted relationship with my mother or someone close to me. And if I have a realization that I have a serious health related, a serious long term illness, and that my life might be not so long, if I get that information, I get the time to speak to my near ones, speak to the people who I am in conflict with, and get in terms with them, get in terms with that person before something happens to me. So there might be people who want to do that, but in the opposite side also, there might be people who do not want to know about the news, just go in the way they are. So this is another important point. And the next part is the total care of the patient. So communicating this bad news helps the patient to be prepared for the last moments, and it'll keep them in a way that they are emotionally much more prepared for the upcoming days, and it can also lead to fulfilling their dreams. For example, we've had situations in which people, for example, a mother has a daughter who is going to get married in the next 6 months. So if she has a life expectancy of 3 months and the bad news is that is communicated with her, then there are chances that she can prepone the wedding and she can be a part of the wedding. So these are all very delicate things which are of very much importance to the patient and family. So, how do we communicate bad news? There is a model which is called the spikes model, which most of you might be knowing. This is the model which has been there for around years, in which the bad news, communicating the bad news is done. So each letter denotes each thing. That is a spikes model. In S, it is setting up the interview. P is perception, I is invitation, K is knowledge, emotion, and summarize. So in setting up the interview, if we have to talk to one of the patient or their family about something which they do not want to hear, and which is going to be a very intense situation, what we have to be doing in the initial step, as an initial step, is that we need to set an environment where the patient and family is comfortable without, so it's written, choose a private, comfortable, and non-threatening setting. And the next step would be, once everything is set and we are in a proper, good environment with the family and the patient, we need to understand their perception about what the disease is or what their current situation is. So it says, uncover what the patient and family thinks is happening. Most often, they might know only the half information. Sometimes they might know a lot of things which are not in line with the diagnosis or the prognosis that we have. So understanding the perception of the patient and family is a very important thing. And the next point is invitation. The next step is invitation. So in this stage, we need to get a lot of inputs from the patient, ask the patient what they would like to know. Even though communicating the bad news is a very important step in the process of communication or in the care of the patient, understanding the patient's perception of their illness and asking them what they want to know. Sometimes the patient might just want to know a slight amount of information, but in certain cases, they might want to know the full information. So, invitation, that is asking the patient what they would like to know, is also a very important thing. The next one is about the knowledge. So, explain to the patient about the illness, and this is a very complicated phase. We are stepping into a very complicated phase in which the information is going to be shared with the patient, and the knowledge about this bad news is going to be given to the patient. So in this is a very important stage which we have to be very careful. And specifically when it comes to healthcare professionals, it might be a tendency for us to use jargon language, so that is very medical terms, and it is very important that we avoid using medical terms and explain to the patient and family in a very simple language which they can understand and they can process this through. And the next stage is emotion. Respect the patient's feeling and respond with empathy. And then it comes to the summarizing part. I'll explain a lot in the coming slides about all these steps as well. So communicating the bad news is like, where maybe we can associate, we can compare this to a surgery procedure, which the doctors and nurses might be doing. So this is a very intense procedure in which there is a requirement of a lot of preparation. So before you do a surgery, you might, it's not you might, you will definitely prepare for a lot of things. And specifically in case of communicating the bad news too, you need to prepare before you say the bad news to the person. So update yourself on the patient's medical condition. We being healthcare professionals, having a good knowledge about what the condition of the patient who we are going to break the bad news is of great importance, because until and unless we have answers to their, or we have a great knowledge about what their medical condition is, we will not be able to explain to them effectively what their diagnosis is, or what their prognosis is, or the questions that they might have in during the session. So it's very important that we update ourselves on the patient's medical condition. The next one is have a clear picture of their emotional status. Maybe if the patient is admitted in the inpatient unit and they have been going through a very tough time for the last 1 month, and that is when we are planning to communicate the bad news with the patient. It's very important that we need to assess their emotional status before communicating the bad news with them. This gives us a lot of idea as in how to talk to the patient, whom to be giving more importance to, and a lot of things related to that. And the next point is allot a dedicated time slot for the process. So this is a way of setting up the interview. So allot a dedicated time slot for the process, preferably a time with no disturbances. Since this is a very delicate process, like I mentioned before, it is very, very important that we set a time and place where this information can be smoothly passed on to the patient and family. And if there is a lot of disturbance in between, it might cause a lot of distress in the patient, and it might be a guilt factor for us too. So it's very important that a dedicated time slot and an environment is set for breaking the bad news. And another main thing is listen actively. Be prepared to listen actively, and only go to break the bad news. Only set up a session if you are in a good state of mind and you have the capability to listen actively to the patient and family. So starting the interview. So I'd like to pause for a moment and ask if anybody has any comments or questions. If you're good to go, I'll move on. Saloni, were you telling something? No. Okay, starting the interview, we need to understand the patients and families' insight about the illness. That is the second step, preparation and perception of the patient. So understanding the patient and families' insight about the illness is a very important point, and invite them to speak about their concerns, the type of concerns they have, and explore if the patient actually wants to know. Sometimes what happens is when we are very prepared to communicate the bad news with the patient, when we go and set up the environment and sit with them and try to speak with them, that is when we might have a clear picture, we might have a deep conversation with the patient, and we understand that the patient is actually not prepared to know the bad news and they do not want to know the bad news. So it is very important that even though we've set up a time for communicating the bad news, we explore if the patient actually wants to know the information. And if yes, if the patient wants to get the information, give a warning shot. So I'd like to speak about the warning shot. So warning shot is as literal as it means, is something that you give before something major happens. So when we have the conversation with the patient, and if the patient wants to know about the bad news, you can ask, like, if it is something serious, would you still want to know? This is kind of a preparation for the patient, and it gives us an insight or gives us a surety that the patient still wants to know. Post warning shot. After giving the warning shot, notice the change in the atmosphere in the room. That is, just before that, the conversation might have been just a conversation. But once you say that if it is something serious, would you still like to know the information? The atmosphere in the room might change. The situation might become more tense and more serious. And in this situation, if the patient does not want to know, the patient will directly communicate with us, either will directly communicate with us, or if the patient does not keep an eye contact with us, give this some time and make sure that the patient wants to know. If there is no eye contact or if there is a change in topic, um, and sometimes the patient can directly tell you that they do not want to know. In these situations, it should be a hard stop and you should not be proceeding with sharing the information with the patient or the family. But if the person looks clearly into your eyes and tells you that they want to know, you can proceed. I hope I'm clear. If there is no eye contact, if till then the patient had really good eye contact with you, and once you gave the warning shot, the patient tells you that patient does not keep the eye contact, the patient slowly moves away their eyes to another and puts their focus on something else, or if they change the topic into something else, makes you need to be very cautious and understand that it's a red flag, and you need to stop proceeding to the to communicating the bad news. If the answer is a yes, and if they keep on looking at your eyes, if they keep the eye contact, then you can proceed. And if you are proceeding, use a narrative approach. So I'd like to speak about the narrative approach. In this, so when we are near a patient, it should be like a process, a whole process. There should be a flow for it. Narrating, it should be like narrating a story to the patient. For example, I can say if there is a boy who's sick, and if it's the mother and father who are the caregivers, if we have to communicate, but with children, it might be a little more different approach than the other adult approach. But then, if it's a 25-year-old boy and he has his mother and father near him, and we want to communicate this bad news with this boy and the parents as well, then be sure that you are narrating the story of the patient to the patient, or whoever, if it's to the family members, it is so. So narrating the story of the patient to the patient itself from the beginning. And when you're doing this, give small chunks of information to this person, and escalate the information gradually. Do not say all of a sudden. If even though we are prepared, we being healthcare professionals are prepared to give the information to the person, this person needs a little time to process the information, because it's going to make a huge change in their, probably it's going to make a huge change in their lives. So giving small chunks of information is necessary, and give pauses whenever required. If you're sharing the news and you see certain changes in their faces or expressions, give certain pauses where the patient gets enough time to digest the new information, and eventually you can escalate the information. For example, the X-ray showed, this patient was admitted in the IP unit for some days now, and there has been an X-ray procedure. So this and all the patient might already be knowing. So what we could say is the X-ray showed something like a shadow, and you can give a pause between that. And the shadow turned out to be a tumor. So this requires a lot of attention and a lot of active visualizing too, in a way which we understand each emotion of the person who's listening to us, and modify our words in a way that it is delivered smoothly to the person. So the shadow turned out to be a tumor, and on further investigation, the tumor appeared to be a cancer, and there we have delivered the bad news to the patient. So some important things we have to be noting here is give pauses, make sure that you give pauses and give the patient a time to digest the new information, and slowly escalate the information. If it's done in the wrong way, if we have to I'll give you an example. If it's done in the wrong way, so if you have to be communicating a very bad news with a patient, we have done an X-ray and it seems to be a cancer. So this is how the wrong information or the wrong way of communicating a bad news can be done. So make sure that there are enough pauses and the information is not directly given bashed onto the patient's face. It's slowly escalated. And this is a very important point. The patient decides the speed of the interview. So even though we have a lot of things arranged in our mind that this has to be said in this point, this has to another thing has to be said in another point, the patient decides how the process has to go and the speed of the process. If the patient takes away their eyes and if they um, if they move away their attention from us, then make sure that you pause the conversation and ask them if they want to know more about it. And only if they want to know more about the bad news, proceed. Otherwise, you can stop even at that point. Finishing the interview. Um, so this is a very interesting part. Finishing the interview. The process can end in two ways. Either we end up telling the information completely to the patient, or another phase is where the patient has had enough for the time being. Maybe, like I said in the previous slide, the X-ray showed something like a shadow. So, some patients at this point might tell us or move away their eyes and show that they're not interested to listen to more or they've had enough. Make sure that they are being comforted or they are given a comfortable situation, and make sure that you stop there because they might have had enough of what they want to know. So finishing the interview involves patient either gets the full information or they've had enough for the time being. And uh, be prepared. The person who is going to deliver the bad news should be prepared for an emotional reaction or a lack of it to the bad news. These are again two extremes where when we deliver the news, we've had experiences both the ways. When we deliver the news, there can be people who are very emotional. They might have a lot of um, anger issues, or they might be angry, or they might start tearing up, they might start crying a lot, or there are situations where people are already prepared for it and there is a lack of emotions to the bad news that we broke. So and if it is an emotional situation, then we need to allow the emotional reaction. It might be tears or anger. We need to allow it to run its course. And this is something very important. When the patient is ventilating the emotions, don't say or do anything. But the thing we can do is we can be with the patient. Mostly, we humans have a tendency to keep speaking, and in this case, that is not going to help. When the patient is ventilating the emotions, make sure that you sit with the patient and be with them throughout the journey, and don't say or do anything. And in certain cases, even our slight touch can be of use to them when they are tearing up, um, when they are being very emotional. A slight touch to their hands or um, all these might be of help, but make sure that it is appropriate and it is not for too long too. And I forgot to mention something. In the spikes model, there's the last step of summarizing, or in the first step there is the setting up of the interview. In this phase itself, what we can do is we need to be expecting this emotional outburst or tears and everything, and the simplest thing that we can be doing is making sure that there are tissues available for the patient if they cry. So that's even a simple thing which we might not think about, but that might be of a lot of help for the patient. uh, so once the emotional reaction subsides, ask the patient if the patient wants any more information. This is the same thing with the family also. If it's the family who's involved and if you're breaking the news to the family, once the emotional reaction subsides, ask if they want any more information. So, usually in this stage, the patient would want to know more about the treatment options or how curable it is. They would still be confused about what can be done next and what the future plans could be. Some of them might be very desperate to know, doctor, is there something more we can do? Like, how much would it be? They might be very curious about the cost and everything related to that. So, in these situations, the person who's dealing with the situation will have to be skilled enough to give honest answers, which are clear and precise. And if the person does not have an answer for that, be honest and tell them that I do not have an answer for it right now, but I can talk to the right person who might have an answer for this and I can connect you with that person. So, the thing that we can do for the patient and for ourselves is that we should be honest, we should give honest, clear, and precise answers to the patient. And some things which we have to note is do not give false hopes, do give achievable hopes. That is, we might not be, even though we are the health professionals who are working with the patient and the family to help solve their all kinds of issues, some things might not be possible for us to do. So, in these cases, do not give false hopes. And if there are certain things which are achievable by us, which are doable by our side, then do give achievable hopes and give clear follow up plans and ask for any doubts or clarifications that the patient or family may still have. And when you're closing the interview, close the interview by leaving the door open, which means keep the keep the doors open for the patient to come back to you whenever they want to. And if they have any clarifications or concerns in the future, they would want to approach you and make sure that that door is open for the patient and family. And post procedure follow up, visit or call the patient within 1 day's time to know how the patient and family has been coping with the new developments. So calling the patient, it can be done by either the person who is sharing the bad news with the patient or by the one who is within the healthcare system and who has a good relationship with the patient to check in, to have a check in on how the patient is doing after this huge information is being shared with the patient. And the next is the patient or family may need further clarifications or more information in the coming days. Therefore, it's very important that we keep on following up with them. So this is the crux of the breaking the bad news or communicating the bad news. If anyone has any questions, we'll take that or we can move on to the next topic. I hope either it's clear to everyone or you are not asking questions.
Yeah, we can move on to the next session. In the meantime, if they have any questions, they can put in the chat box. So after that, we will discuss it.
Thank you, Sister Sheba. So the next part is collusion. So I'd like to know who, if anybody has a clear idea of what collusion means. If you have an answer, please do put it up in the chat box or just unmute your mic and speak.
It means that if the family members don't want to tell the diagnosis to the patient.
Great, that's absolutely right. So thank you, Monica. So it is an act of shielding the information from a particular individual. So by shielding in palliative care, collusion is mainly done for, so the information is mainly shielded from one of the family member. It is mostly the patient from whom the information is being shielded from. This is not because they have some conspiracy in mind or anything. It's just to protect their loved ones from being harmed. So in this case, the people who are going to harm that patient, in for example, if it is a family member who hides an information from a patient, for the family member, the people of harm might be the healthcare professionals or the like the doctor, nurse, or the social worker, psychologist, whoever it might be, because we are the ones who know the information, who know exactly what the diagnosis and prognosis is, and they might be really scared if we might end up telling this diagnosis or prognosis to the patient. So, uh, so collusion is an act of shielding the information from one person in palliative care. The information is mostly shared, mostly shielded from the patient because uh, from the patient or a really loved one, because they care for that patient a lot and they do not want any kind of harm to reach to them. So, in case of collusion, acknowledge the family's fear. We need to understand that fear that the family has is just coming out of their care and their love towards their loved one. And do not challenge the family's belief. In certain cases, the caregiver might have a belief that if the patient comes to know about this disease, the patient might end his life, or the patient might go depressed and they might not even do the activities that they're doing right now. So even though we might have a strong belief that it is not going to happen, do not challenge the family's beliefs. Acknowledge the family's fears and agree to collude and maintain that. If the family does not want the patient to know, make sure that the patient doesn't know and be in terms with the family, because this will calm them down and this will help them trust the healthcare system or the people who are involved in the care of the patient. Eventually, what we can do is we can work with the family or the caregivers who are involved in the care of the patient. Is my screen visible to all of you?
No, ma'am, it's not visible.
Please give us a moment. So I was talking about how we have to be communicating with the family when we are agreeing with the family to collude and maintain that collusion. We need to work with the family to build a relationship with the family and cater their emotional needs. And most importantly, we need to listen to the family about uh, about the concerns they have, and some people might even express to us how much they love their uh, how much they love the patient who they are in their relationship with, and we need to give this an ear and listen to them. Next slide, please. Orient the family about the benefits of communicating the bad news with the patient. It is like we mentioned, like we talked about before. Um, there is a need that the news is communicated with the patient. The bad news is communicated with the patient because there's a lot of elements involved as in planning for the future and a lot of things that we spoke about before. Therefore, even though the family wants to collude the information from the patient, and we agree to stick to that decision, it is our responsibility to orient the family about the benefits of communicating the bad news with the patient and slowly bring them into a position where they would want to communicate the bad news with the patient. And since we have this in mind that the patient has to be having this information about the bad news, it is normal for our side to push the agenda towards communicating the bad news. And sometimes this happens from our side too. So it is very necessary that we do not push the agenda. we need to have patience. We need to continue working with the family, be prepared for failures, and continue until the family is ready to share the information with the patient. Until then, we have to be prepared for failures and we have to continue to do the best we can for the patient. Next slide, please. Okay. The next part is dealing with emotions. So we all might have an idea of how to deal with a person who is crying or a person who is in tears. But it is often a question about how we deal with the emotions, specifically when it is anger. Next slide. So, what do we do when someone is angry? How do we manage when someone is angry? So, there are certain things we can be doing to do when someone is angry, is facilitate the anger to flow away. So, before that, I'd like to speak about how anger works. So, anger is a very high energy procedure or a high energy emotion which consists a lot of negative energy, and this can even turn out to be very harmful to the people surrounding the person who's angry. And if there's energy, there has to be something which adds to the energy. So, if something has to burn, there has to be a fuel to it. Anger is kind of similar to that. If a person has to be angry, there has to be a reason why the person is angry. And this person's anger can aggravate if there is a fuel added to it. For example, if the person standing near him or her or whoever it is, reacts in the similar way, reacts in a similar angry way, there are chances that this person might end up being more angry and being violent. So it is very necessary that we cut down the fuel which supplies this anger. So, how do we do that? We facilitate the anger to flow away. And mostly when people are angry, uh, we can even consider ourselves in an angry situation. If we are very angry and we are not able to control our emotion, we tend to stand up and express our anger. So mostly the person who's angry stands up, and if the person stands up, it is better that the person who's listening to them also stands up and tries to listen to them. And there should be a balance of confidence and at the same time um, might be a sign of listening. If we can give them a sign of listening and at the same time be confident enough so that the person does not attack us back, there should be a proper balance between these two. So if our spine is respectfully in a slight kyphosis, that is if we slightly bend our spine and stand, and we are in a position where we listen to the person who is angry, along with this keeping our eye contact and maintaining that confidence in your eyes. These body postures itself can kind of calm down the person who is angry, and let the anger flow through the person. Let them react in a way where they vent out all their emotions, because this is something heavy. It is, we are talking about someone who is very close to them, or it might be the person itself. So since we know that this is a very hard thing to be digesting, it is necessary from our side to respectfully listen to them and let them allow their emotions to flow through. And once the situation is calmed down to a bit, we need to sit down and discuss with this person about their emotions and how the situation can be resolved, and if there are anything which can be corrected from their side. At this situation, once the person is calmed down and the emotions are subsided, we can talk to the person about this. Back. So when there is one person angry at us, it is different from when there is a lot of people who are around us and who are angry. So this, what I told just now, is when there's just one person near us who is very close to the patient, who's being angry, and in that situation we might be able to deal with the situation in this protocol. But if it is the huge crowd of people who are angry at you, and if it is a lot of family members who are coming, then it is better that we walk away from that situation and make sure that the right process is taken away. If it's a law and order problem, we need to move in that process. But if it is just, I'm just talking about dealing with one person who is angry or a small family who is angry at us. So in that cases, we can facilitate the anger to flow away, listen to them, be respectful, and at the same time be confident. Sit down with them. Once the situation is subsided, sit down with them, talk to them about the issue, and try to resolve the situation. So this is the end of my presentation. I hope you all have got an idea of how to be communicating the bad news and the necessity of communicating the bad news and the concept of collusion, and also how to be dealing with the person who's angry. So Sister Sheba, can we have the floor open for questions? Or
Thank you, Manisha, for the detailed presentation. If you have any questions, please ask her. Otherwise, you can put the questions in the chat box. I think senior, few questions already there. We can discuss that question and then.
Yes, ma'am. We do have some questions like, can this communication process be supplemented by any video or?
This question is not quite clear for me. So if this
Actually, I think the participant is asking for some kind of video that clarifies this communication class. How we will come to know how much patient wants to know about condition, about patient's condition. Question from Shika.
So the video, there's just one video available. It's like a role play where Dr. Raj and someone else talks to each other, and that's quite an useful video. I was planning to show it, but then because of the lack of time, I couldn't show it. So yes, what was the other question?
Do you have that video, Manisha?
It's there in YouTube. It's there in YouTube, available for everyone.
YouTube. Okay. If we have time,
We can share the link, or we can share the link in the WhatsApp group if possible.
Okay.
How will we come to know how much the patient wants to know about the condition? So this is where there's a requirement of a lot of skill, and we need to be, this is the stage in which we need to invite the questions from the patient side, and the next step is asking them how much they want to know. So this is a major portion in the spikes model, where we need to set a boundary to how much the patient wants to know. And even during the communication of bad news, like I mentioned before, even though we feel that the patient is prepared to hear the bad news, and if they tell us that they want to know the bad news, in between there might be chances that they withdraw from it and they've just had enough of the information that they want to have. So it depends on the situation and depends on how much, it depends on the experience also. The skill is built through experience of communicating the bad news.
Shiba ma'am, I think there is no other questions. Can we move to the case presentation? Shiba ma'am.
Any other questions?
Shiba ma'am. Ma'am, can we move to the case presentation?
Yeah, so before moving on to the case presentation, I'd like to highlight few things about today's presentation. As Manisha said earlier, when we breaking the bad news, you can use Spike's protocol. So that means the first TSC setting up the interview. The P is you have to know about the patient's perceptions, and the I means invitation. That means so after you will understand about their illness, that insight about their illness you should ask them. So would they like to know about their diagnosis? Then if they are agree to willing their that hear their diagnosis, what you have to do is before that you have to do the adequate knowledge about the diagnosis and the information, and you have to prepare your own share the information. And also in between, when we breaking the bad news, definitely in between some emotions will come up. So you have to be prepared how to
Sister Shiva, we've lost you.
that how to can you hear me now?
Yes.
Ma'am,
Yes, okay.
I think it's better to turn off your video.
Okay.
Okay,
What
go
about
on.
now?
Okay, it's okay, ma'am. Go on.
Oh, okay. So the next thing is in between. Sometimes, as I said earlier, some emotional. You have to prepare to handle their emotion, the emotions. So they might be crying. So in between, you will give some professional touch, and then also you have to give some reassurance. And also you should be empathetic, and so you should be empathetic, and the last one is you should be have a strategy plan for the future. And you have to summarize that things. So you will give a good reassurance what you are going to do for that patients after the you are breaking the diagnosis. You have to give a good idea about that. You have to give better words like we are here to help you. If you have any difficulty there, we are here. So you can come here anytime. So we will care for you. That kind of if you develop any symptoms, we will take care of you and your family. That kind of that things you have to share, then they will be comfortable. So coming to the collusion management, as Manisha said earlier, this is very very important. Without the caregiver's consent, we can't do anything. So you have to convince the caregivers first, because we all know the patient has to the patient has the right to know the diagnosis, but without a caregiver's permission, we can't tell the truth to the patients. So we have to convince the patient caregivers first. We can conduct the family meeting, and also you can tell them how to break the bad news. Then they will realize. That all of a sudden we won't tell your loved ones you have a cancer like that. So we will how to break the bad news, the steps you have to break with the caregivers. Then they will then they will accept. Okay. So thank you. We can move on to the case presentation.
Sister Shiva, time
Soni
permits.
Kumari.
If
Yes,
time
yes.
permits, do you want us to share the video?
Yes, yes. We maybe after the case presentation we can
Sure.
yeah, we can show that video.
Sony, ma'am, please unmute from your end. Hello, Sony, ma'am. Ma'am, kindly unmute.
Good afternoon, everyone. My name is Mani Kumari Das, staff nurse from Prem Jyoti Community Hospital, Bararwa, one of the Emmanuel Hospital Association unit. So coming to the patient history. Age 65 years old, female, diagnosis autoimmune hepatitis, PBC overlap, autoimmune encephalitis, hepatic encephalopathy, and systemic hypertension. Next slide. Then contains loose stool, weakness, nausea or vomiting, disturbed sleep, not able to walk, weakness, abdomen pain and swelling, swelling in the leg and ankles.
Sony. Hello, Sony Kumari. Hello.
Hello.
Ma'am, please continue.
Ma'am,
Ma'am, actually, we can hear you. Your voice is breaking.
ma'am.
Ma'am, please talk. I think our case presenter, Ms. Soni Kumari Das, is having some network issues with her. Can anyone please present this case for her? Just to read out.
Ma'am, next slide, ma'am, please.
Okay.
Sony is still not audible.
Sony, you are not still audible.
Hello.
Now it's clear, but when you start talking, your voice is breaking. We can't hear you clearly. Sony Kumari, can you please log in again once again?
Of the skin, whitish of eyes, flap present, glossitis present, very lethargy, weakness. So doctor diagnosed autoimmune hepatitis with PBC overlap in July 2021. She got admitted in private hospital, done treatment for 5 days and discharged. History of icterus plus, ascites plus, systemic atrial hypertension and over the body and hip region. Next slide, ma'am. On examination, altered sensorium, temperature 103 degree Fahrenheit, pulse rate 114 beats per minute, respiratory rate 22, BP 140/90, SpO2 99%, GRBs 85 mg per year. On physical examination, yellowish pigmentation of the skin, whitish of eyes, leg are swelling, and she was unable to walk. Treatment and significant investigation, ALT 248, AST 262, ALK to 222.9, TB 34.7, DB 23.0, which is very high, albumin 3.8, protein 6.9, sodium 146.7, potassium 2.03, chloride 105.8, Iron 1.29 and pH was 7.3, HB 9.0, TLC 21,600, platelets 43,000, manually 75,000, urea 88.1, creatinine was 1.06. On psychosocial aspect, 65 years old widow woman living with her elder son. She have 5 children, 2 sons and 3 daughters, and they were living separately and not caring and helping them. She had felt isolated. She feeling uncomfort and uneasy to convey everything to her elder son, like dressing. She was very depressed as none of daughter were supporting. She used to cry and say, there is no hope for living, no meaning to live. She belonged to Hindu family. On observation, she had sleeping disturbance due to recalling how she gonna to live in future and who will take care, and hopelessness. Medication, high antibiotic, injection meropenem 1 gram BD, injection PCM 600 mg PRN, syrup lactulose 30 mg Q6 hourly, injection labetalol 20 mg PRN, UDCA tab 550 mg BD, tab rifaximin 25 mg, tab ivermectin, intravenous NS 5% dextrose and DNS. A main concern for this patient: pain, bed sore, emotional unstable, psychological support, disturbed sleep. Summary: 65-year-old woman had a history with the diagnosis of
Sonia, she left, I think.
Actually, she is having internet issues, ma'am.
Okay. Shall I read it out?
Oh, sure, ma'am. Please.
Yes. Summary: 65-year-old widow woman had a history of diagnosis of autoimmune hepatitis with the PBC overlap. She falls sick and admitted in hospital for future medical treatment. She have 5 children, but not good caring support from them, except elder son. So she felt isolated from the family members, which made her no hope to live long. Knowing this history, nurses given extra more care towards her and continuing the medications. So discussion points. So how to provide palliative care for this patient. The second question is how we can support to the patient and bring hope. Then the third question is how to communicate with her children properly and bring them with her. Okay. So this is about today's case presentation. If you anybody need any more clarification regarding this patient story, please ask her. I think she has joined. Uh,
yes.
Senior, did she join?
Actually, she is here, ma'am. But I think her
She's here.
network is
Okay.
not good.
Okay. Thank you. Thank you. So anybody need any more clarification regarding this patient story, please ask her. Otherwise, we can move on to the patients, the discussion points. Manisha, over to you.
I know I'd like to hear from the participants about what they think about this and how palliative care
Yes,
can be
yes.
provided to the patient.
Yeah. So we can take first questions. So we would like to hear from the participant side. If you see this type of patients in your settings, how will you support? So we need to support Sonia's sister for further care for that patient. So or your comments and suggestions is better. So either unmute yourself and talk or put your comments in the chat box. Anybody?
Sister, if there's no one coming up with an answer, maybe I can give my inputs on this. So, how to provide palliative care for this patient? So, what I understand is that this is an elderly patient who requires a lot of support, and when it comes to palliative care, we talk about the total pain and all the aspects, including the physical, psychological, social, and the spiritual aspects. So, providing palliative care to this patient means, for me, it means not just dealing with the physical aspects. It also means dealing with all the other three aspects as well, including the psychological, spiritual, and the social aspects. So, and in when I combine the last two questions too, I feel that there is a necessity of understanding the family dynamics and also having a clear picture of the echo map of the patient, like what support systems the patient has other than the family. It might be the temple or the priest or the local parties or whatever that might be. So, if there's a lot of systems, if we can find out what other systems than just the family who can be a part of her care, that would be very helpful. And also, something very important is understanding why, or trying to understand why there's a relationship gap between the mother and the children. And I don't know about her husband. So, the reason for their disrupted relationship or their strained relationship could be explored more. And if the reason can be explored, maybe we can talk to the children about the actual diagnosis of the patient and how serious that is, and we can tell them about how this mother wouldn't be able to deal with this alone. And so everything is based on the communication with the family and understanding what the issue between the family and the mothers. I feel that is of great importance. And first of all, in palliative care, treating her immediate physical pain or whatever the physical symptoms are is also very important.
Shiba ma'am.
Yes, Sony, I'd like to know about where is she? Did she admitted in the hospital or uh, she is in home now? Uh,
Ma'am, she died,
I
ma'am.
want to know.
After,
She died.
ma'am, she died, ma'am.
Okay,
Yes, ma'am.
okay, okay. So yeah. So as Manisha said earlier, if you see this type of patient in future, you should that take a proper history. Why that family relationships are broken? That things, if possible, if you conduct a maybe if they are not willing to come to the hospital, so you can give take the telephone number and give a call and ask them to come to hospital, or you can discuss through the phone. So if they are, after that, if they are willing to see her or his mother, so they can come and see their mother. Maybe they if they have any problems, try to convince them. So right now their mother that her or his mother is not well, so she wants to see you, so please come and see at least once. So that kind of information you could pass to the children. And also so seek some NGO support also. If here one elder son is take care of that patient, that little bit difficult for that patient, because that male person, he has to do all the things. So that is the major the psychosocial issue. So you can connect with the NGO, so NGOs like any palliative care center nearby, so you can connect with them. So from there they'll get support. So so we have time. I think we can show that video. Manisha.
Yes, 1 minute, please.
Okay, thank you.
I'm still finding it difficult to swallow, doctor. The pain is little better with the medicines you gave me.
Shalini, how are you today?
I'm still finding it difficult to swallow.
That's the end of the video, Sister Reba.
Okay, thank you. So, anybody have any doubts? Regarding today's presentation about communicating bad news, collusion, or case presentation, any doubts you have, please unmute yourself and ask.
Yeah, so I just saw in the video that the doctor was actually holding the hand or having his hand on the hand of the patient. And I think it's not always appropriate. So I would be very careful with touching the patient in that situation, but giving the space to actually use their hands or use their body in the way they need it at that moment.
Thank you. Thank you so much for bringing in that. That's indeed a very true statement, Salome. So that is what I had mentioned in my presentation, that a touch might be of a lot of help for some patients or some of the family members, but it might not be true in all the cases. So we have, like you mentioned, we have to be always be very careful of what kind of touch we use and how much, even the length of the touch might be of great importance. So this should be based on our knowledge of how much that person might want us to be in touch with them, or it depends from situation to situation, and we have to be very careful about that. That's true. Thank you for bringing that in.
Yes, that is true. And also, I want to mention one thing regarding the touch. As Manisha said earlier, touch is good, but sometimes it is bad. But in between the emotional situations, if you give a professional touch, so they will be free to ventilate their emotions. In my 20 years of experience, so I have seen many things like that. If you give a professional touch in between the emotional, that if they are crying or if they express their emotions, if you give a professional touch with to the patient, so they'll cry more and ventilate their feelings freely. That is why that is what my experience. So it should be the professional touch.
Ma'am, there is a comment on the chat box from Sonia. Thanks for the session, ma'am. It was really informative. Therapeutic touch technique is acceptable, I think. Before that, we must consider cultural values.
Yes, definitely we should consider the cultural values, but in between, if you give a if you have a good nurse patient relationship there, so your touch should be in the professional way. That is why I am understanding, if without that nurse patient relationship, we can't do the touch. So if you do a proper relationship, good relationship with the patients, definitely they are willing to ventilate their emotions. And in between, if their emotions increase, you should give a professional touch. I hope your that questions answer is clear. Any other questions?
Shiva, if there are questions, shall we wind up the session?
Yes, yes. If you don't have any questions, we can wind up the session. Okay. Thank you, Manisha, for the detailed presentation. Thank you, Sony, for the case presentation. So I hope all of you get a good idea about communicating bad news and collusion breaking and anger management and all. So thank you once again, all.
Thank you all. Especially thank you to Manisha. Thanks to Manisha. Looking forward to have many more communication sessions with you again. And I have shared the feedback link with you all. Kindly go through it. A few of you are submitting the feedback, like 6 or 7 of you are only filling up the feedbacks. So kindly everyone, please go through the link. It will take 1 or 2 minutes at least. Please check it out. Please fill your feedback link and we value your feedback. Kindly do that. Thank you all. We'll see you on the next class. Bye.